This presentation will discuss the use of Aprepitant versus Ondansetron in the prevention of postoperative nausea and vomiting in adult patients undergoing general anesthesia. This will be presented by Alyssa Staubitz. At the conclusion of this educational module, you will recognize the prevalence of PONV today despite current advances in healthcare, recognize the significance of addressing the current problem with PONV, understand the mechanism of action of Aprepitant in the prevention of PONV, and understand Aprepitant's best use in the prevention of PONV. PONV, along with pain, is one of two of the most common patient complaints reported after surgery and is the leading cause of unplanned inpatient admissions. PONV rates remain high despite improvements in healthcare, including the availability of multiple prophylactic antiemetic agents, the use of minimally invasive surgical techniques, and the availability of short-acting anesthetics. Incidence rates for inpatient surgeries range between 30 to 50%, with rates as high as 70 to 80% for patients with multiple risk factors. In one study of surgical patients, patients rated vomiting as the #1 most concerning possible anesthesia outcome. High PONV rates contribute to patient dissatisfaction with anesthesia, lengthened PACU stays, and increased healthcare costs. PONV has been implicated as the cause of delayed PACU discharge, resulting in up to twice the time in PACU than patients who did not experience symptoms. Not only is this a problem for patients, but for the efficiency of patient flow from the operating room to the PACU. Disruption of patient flow can result in increased healthcare spending. Effects of PONV can range anywhere from postoperative patient dissatisfaction or distress to postoperative morbidity. PONV can result in patient complications including pulmonary aspiration, wound dehiscence, esophageal rupture, subcutaneous emphysema, pneumothorax, unplanned hospital admissions, and more. Consensus guidelines published by the American Society of Anesthesiologists in January of 2014 set forth 8 different recommendations for the management of postoperative nausea and vomiting. 1. Identify patients at risk for PONV. 2. Reduce baseline patient risk factors for PONV. 3. Administer PONV prophylaxis with 1 to 2 interventions for adults at moderate risk. 4. Administer 2 or greater interventions for patients at high risk for PONV. 5. Administer prophylactic therapy to children at increased risk for postoperative vomiting. 6. Administer antiemetic agents to patients with PONV who did not receive prophylaxis or in with whom prophylaxis failed. 7. Institute PONV prevention treatment in the clinical setting. 8. Use general multimodal prevention to streamline implementation of PONV policies. A preoperative risk assessment tool used to identify high-risk patients is the Apfel scoring system, which is based on 4 independent risk factors. These include female gender, non-smoking status, history of PONV and/or motion sickness, and use of postoperative opioids. Listed here are the differences between the most commonly used antiemetic, Ondansetron, and the less commonly used antiemetic Aprepitant. Ondansetron is a serotonin 5-HT3 receptor antagonist that is administered IV, needs to be redosed every 6 hours, and has a half-life of 4 hours. Aprepitant is a neurokinin 1 receptor antagonist that is administered PO once preoperatively and has a half-life of 40 hours. The research from this project had the following study findings on Aprepitant. 1. Aprepitant provides superior protection against nausea, vomiting, and need for rescue antiemetics in comparison to Ondansetron. 2. When administered in combination with Ondansetron, Aprepitant is more effective than administration of Ondansetron alone in prevention of PONV. 3. Aprepitant is superior to Ondansetron in prevention of postoperative vomiting. And 4. Aprepitant delays time to first vomiting episode. Aprepitant exerts its antiemetic effects via NK1 receptor antagonism. It works primarily in the nucleus tractus solitarius as well as in areas of the reticular formation. It inhibits the effects of substance P, which is normally released in response to input from the gut and the brain. Without NK1 receptor antagonism, substance P activates NK1 receptors, resulting in the vomiting reflex. The studies reviewed for this project found that patients who receive Aprepitant preoperatively are 2 times as likely to be protected against vomiting in comparison to those who receive ondansetron. It has been argued that aprepitant should be administered for PONV prophylaxis, specifically in patients at risk for PONV whom vomiting could result in serious complications, such as in patients who require jaw wiring postoperatively. The following are recommendations on the use of aprepitant based on the findings from the studies reviewed for this project. 1. Administer aprepitant in patients at moderate to high risk for PONV or patients with 2 or more risk factors on the Apfel scoring system. 2. Administer aprepitant in patients at risk for serious complications related to postoperative vomiting. 3. Administer aprepitant as combination therapy with ondansetron for more effective PONV prophylaxis. And 4. Administer aprepitant no greater than 3 hours prior to induction of anesthesia at a dose of 40 milligrams PO. In summary, the evidence suggests that aprepitant, when administered in combination with ondansetron, shows improved effectiveness compared to ondansetron alone. A significant advantage of aprepitant is its ability to reduce the incidence of postoperative vomiting. While aprepitant may not be indicated for all patients presenting for general anesthesia, it may hold high value in the patient at increased risk for PONV or increased risk for serious adverse effects in the presence of postoperative vomiting. Administration of aprepitant has the potential to lead to improved patient outcomes and increased patient satisfaction.